Surgery of Ear by Glasscock and Schamberg, Chapter 28, Tympanoplasty, Tympanic Membrane Repair. Tympanoplasty grafting techniques. There are two tympanoplasty grafting techniques, underlay and overlay. Graft placement in the underlay technique is medial to the tympanic membrane remnant or annulus and manubrium of the malleus, whereas in the overlay technique, graft placement is lateral to the tympanic membrane remnant and is medial to the manubrium. Both techniques give excellent results provided they are properly performed by experienced surgeons. The overlay technique has been associated with higher incidence of blunting of the anterior sulcus and graft lateralization, which may result in significant conductive hearing loss. Other drawbacks of this technique are formation of epithelial pearls from a failure to completely remove the squamous epithelium of the ear canal or tympanic membrane remnant and delayed healing, most likely, resulting from completely removing and repositioning the skin of the ear canal. Upon repositioning the ear canal skin, areas devoid of epithelium may develop that can contribute to formation of granulation tissue and delayed healing. These potential complications are avoided in the majority of cases performed with the underlay technique. The overlay technique is overall a more technically demanding procedure and requires considerable experience. Underlay technique. The technique described in this chapter was initially reported by Glasscock in 1973 and is used by the author in the majority of tympanoplasty cases. Since facial nerve monitoring is performed during the procedure, short acting paralytic agents can be used only at the induction of anesthesia. Administration of nitrous oxide gas should be avoided because it diffuses into the middle ear and can displace the graft. After the ear has been pricked and draped, the external ear canal is injected with lidocaine 2% xylocaine with 1 is to 1 lakh epinephrine. A vascular strip incision is outlined by making an incision with a 72 beveled knife blade just lateral to the tympanic canalus, followed by one along the tympanomastoid suture line and one along the tympanomastoid suture line using a 67 beveled blade. A postauricular incision approximately 5 mm behind the postauricular sulcus is performed and bleeding is controlled with electrocautery. By grasping the auricle firmly and pulling it forward and outward, identification of the loose areolar tissue in the avascular plane overlying the temporalis fascia is greatly facilitated. A Whitlander retractor is placed horizontally to hold the auricle forward, and a scene retractor is placed by the assistant under the superior part of the skin incision and pulled laterally to expose the temporalis fascia. Separation of the areolar tissue from the temporalis fascia is facilitated by injecting this area with local anesthetic solution. An incision is made at the level of the linea temporalis and is carried down to the level of the temporalis fascia. The areolar tissue is dissected using Metzenbraun scissors. The harvested areolar tissue is squeezed out on a polytef Teflon block and placed under a gooseneck lamp on the back of the table for dehydration. A T-shaped incision is made in the musculoperiosteal tissues overlying the mastoid cortex with the horizontal component in the avascular plane of the linea temporalis and the vertical component between the mastoid tip and the mid portion of the horizontal incision. Using a Lampert elevation, musculoperiosteal flaps are elevated posteriorly, superiorly, and anteriorly. The vascular strip is elevated out of the ear canal and is kept by repositioning the previously placed self-retaining retractor. A second self-retaining retractor is placed vertically between the temporalis fascia and mastoid tip. This allows for excellent exposure of the ear canal, tympanic membrane, and middle ear from the post-auricular region and eliminates the need of working through an ear speculum. In cases with a prominent tympanosquamous suture line, it can be difficult to elevate the vascular strip out of the ear canal with this maneuver. In such instances, using the surgical microscope through the postauricular area, the attachment of the vascular strip to the tympanosquamous suture line is incised with a 67 beveled blade, and the strip is then gently elevated out of the ear canal. Failure to recognize this situation may result in disruption of the vascular strip during elevation with the Lambert elevator. At this point, a canaloplasty is performed if visualization of the anterior sulcus is limited by an anterior wall bulge. The canaloplasty facilitated proper placement of the graft and adequate inspection of the tympanic membrane in the post-operative period. Next, the skin of the inferior ear canal is elevated to the fibrous annulus, developing the inferiorly based flap, followed by elevation of the superior flap. The middle ear is entered, the status of the ossicular chain is determined, and any middle ear pathology is removed. In particular, markedly post polypoidal mucosa, granulation tissue, and cholesteatoma are removed from the middle ear. Mild mucosal polypoid changes generally revert to normal once the perforation is closed and the other middle ear pathology, such as cholesteatoma, has been removed. Cholesteatoma matrix around the stapes superstructure and over the promontory is removed at very end of the procedure in order to avoid prolonged exposure of the inner ear in case of accidental opening of the oval window or a fistula. Cholesteatoma matrix can be removed from the stapes superstructure using microcup forceps or a Crabtree dissector in the dissection motion proceeding from the posterior to anterior and paralleling the stapedial tendon. It is very important while this is being performed to avoid any injury to the stapes. In case minimal fracture of the stapes footplate occurs with leakage of perilymph, then the involved area should be gently packed with areolar tissue. If the matrix of the cholesteatoma is very adherent to the stapes superstructure or horizontal facial nerve, it can be left in place in order to avoid injury to these structures. Usually, during the second stage procedure, 1 year later, the cholesteatoma remnant has formed a pearl that can be removed much more easily. The surgeon should be vigilant for any dehiscent high jugular bulb, exposed horizontal segment of the facial nerve, and dehiscent internal carotid artery in order to avoid major complications. Jacobson's nerve, the cochlear reform process, the Eastern tube orifice, the round window niche, and the stapedial tendon are very constant, reliable, and useful middle ear landmarks, which, when encountered, can orient the surgeon. Should the surgeon become disoriented because of extensive middle ear pathology, he or she should immediately stop working in an unknown area, identify a region of known anatomy, and then proceed to the area obscured by pathology. The sinus tympani cannot be visualized directly by any approach to the middle ear and can only be inserted indirectly using a small mirror, bucking gum, and with an endoscope. Extension of disease into the facial recess may necessitate a mastoidectomy with opening of the facial recess. Upon completion of disease removal, gel film is placed over the medial wall of the middle ear to prevent adhesion formation, and the middle ear is packed with absorbable gel form. The properly sized dehydrated areolar tissue graft is placed medial to the tympanic membrane remnant, draping posteriorly over the posterior canal wall. For cases with total tympanic membrane perforations, an incision is made in the superior aspect of the graft to facilitate insertion medial to the manubrium. Small pieces of gel foam are placed over the graft for stabilization, and the canal skin films are replaced for their original position. Antibiotic ointment is left over the gel form. In cases having cholesteatoma and or a retraction pocket, tracheal cartilage or conchal cartilage with or without attached perichondrium is used to reconstruct the tympanic membrane in the posterior superior aspect and or the attic to prevent mm, recurrent retraction. Using a Lambert ear speculum, the ear canal is inspected and the proper position of the canal skin flaps is ascertained. One or two of Pop's earwigs, Mirocil, impregnated in antibiotic ointment, are inserted into the lateral aspect of the ear canal to keep the flaps in proper position. The post-auricular incision is closed in two layers with 3-0 vicryl, and a rubber band drain is uh, is left in the most dependent portion of the incision. A master dressing is applied at the end of the procedure. The dressing and rubber band drain are removed the next morning. Denuding perforation edges. Prepare margins for removal with pick. Typical design for tympanomeatal flap. Line of incision. Endoral incision. A. Endoral incision. B. Separation of bony cartilaginous junction. C. Mastoid exposure via the endoral incision. Mastoid exposure via endoral incision, spine of Henle, temporalis muscle. The vascular strip is outlined with number 67 beveled blade. B. A standard post-auricular incision is used to expose the temporalis fascia. C. A large piece of loose areolar temporalis fascia is removed, pressed and dried under heat lamp. Note the T incision used to expose the external auditory canal. D. The vascular strip is lifted out the external auditory canal and placed under the anterior blade of the self-retaining retractor. Continued. E. The inferior flap is elevated into the fibrous annulus with a house number 2 knife. F. Cup forceps remove mucosa from the under the fibrous annulus. A moist absorbable gelatin sponge gel form is placed into the entire middle ear space starting in the eustachian tube orifice. The gel form is placed into the middle ear so that it lies under the annulus anteriorly. C. When the inferior and superior flaps are replaced, the graft is held securely in position. D. The ear canal is filled with polymyxin B and bacteriocin polysporin ointment instead of packing at the end of the procedure. Overlay technique. Exposure of the ear canal is accomplished through a post-auricular approach as in the underlay technique. After the vascular strip is removed from the ear canal and is kept folded in the post-auricular area with a self-retaining retractor, the skin of the ear canal medial to the bony cartilaginous junction and the squamous epithelial layer of the lateral aspect of the tympanic membrane remnant are completely removed and kept in saline solution for use later in the procedure. The tympanic annulus is left in place and canaloplasty is performed if necessary. Any middle ear pathology is removed as in the underlay technique. The middle ear is packed with gel form and the graft is placed lateral to the tympanic annulus and medial to the manubrium to prevent lateralization. To accommodate proper placement of the medial to the manubrium, a slit is made in the superior aspect of the graft. The graft should be long enough to extend over the posterior canal wall. In order to avoid blunting of the anterior sulcus, the caution is needed to avoid draping the flap over the anterior canal wall. The previously removed gel form removed, epithelium is placed in its original position and gel form packing is placed in the anterior sulcus to avoid a dead space and blunting by the formation of fibrous tissue. Gel form is placed on the lateral aspect of the graft as well. Finally, the vascular strip is returned to its original position and the ear canal is placed with one or two pops ear wicks impregnated in antibiotic ointment. The postauricular incision is closed in the similar fashion with the underlay technique and a master dressing is applied. Canaloplasty. Canaloplasty is performed in cases with a bulge of the anterior bony wall that causes poor visualization of the anterior sulcus, failure to secure good exposure of the anterior sulcus during tympanoplasty may result in failure due to improper graft placement. The canaloplasty figure is performed as follows with the beveled blade number 74. A horizontal incision is made medial to the anterior wall bulge and the above the anterior sulcus within a beveled blade number 67. Two vertical incisions are placed on either side of the horizontal incision and are extended laterally on the anterior canal wall encompassing the area of the obstruction. The created skin flap is elevated laterally up to the level of the bony cartilaginous junction and the bony protuberance is exposed. Using continuous suction, irrigation, and a high speed drill, the obstructing bone is removed until adequate exposure of the anterior sulcus is achieved. Meticulous dissection is needed in order to avoid the injury to the glenoid fossa capsule. A prominent spine of Henle should be removed when interfering with visualization.